We at the femur team works to address the causes of fetal and infant loss in our county. And one of our main focuses that we've discussed over the past several years has been on maternal health, especially on chronic health conditions and how that impacts pregnancy outcomes, both for mom and baby. And we know that healthy pregnancies begin long before conception, but often weeks have passed of critical development before a mom even gets in to see a prenatal provider. So what we wanted to talk about today is more of the reproductive life course perspective, with a focus on the importance of care before and after the prenatal period. Our panelists today will provide us with a brief introduction to the continuum of care, and then we'll follow that with a facilitated discussion. We have several questions prepared already, and then we'll save some time at the end for participant questions. All participants are muted, so if you do want to ask a question, please type it into the chat. I'll be monitoring the chat box as we go here. We have with us today Dr. Abby Aina and Dr. Donna Neal from the Center for Maternal and Fetal Medicine. Dr. Aina is an assistant professor with the Johns Hopkins School of Medicine, whose clinical expertise includes high-risk pregnancy conditions and the prevention of preterm labor. Dr. Neal is also an assistant professor at the Johns Hopkins School of Medicine with clinical expertise in high-risk pregnancy, labor and delivery, and gestational diabetes. Both are key members of our femur team and have provided critical guidance and education not only to our team, but also to their patients and to a much wider audience through some great video question and answers on some important pregnancy topics that are available on Howard County General Hospital's website. And those are great if you want to check them out. So without further ado, I will start with their introduction.
Hi, everyone. This is Abby Aina. Sorry, you can't see us, but we wanted to just start this discussion by talking about what makes for a healthy pregnancy. Our goals for pregnancy are to get mom and baby through the course of a pregnancy safely. And so sometimes to ensure that, we would like to prepare moms ahead of time. Many women don't realize that they're pregnant until they're, a few weeks in, and sometimes underlying conditions can make it more risky and make the pregnancy more problematic. So our goals with this discussion are primarily going to involve how to keep yourself in the best health as you contemplate becoming pregnant, and also how to keep yourself healthy once a pregnancy has concluded.
Next slide, please. Hi, everybody. This is Donna Neal, again, working with Abby as high-risk specialist. Can you advance the slides, Aaron? Great. So we thought in terms of this presentation, some hot topics. Number one, optimization of chronic medical conditions. That's what Dr. Aina was sharing in terms of, if you know you have high blood pressure or diabetes, for example, we know we want to make sure those conditions are stable before you enter a pregnancy, because we know when any underlying medical condition is not stable, then that increases the risk for adverse outcomes during a pregnancy. Similarly, sometimes there are dietary modifications that need to be met. The most important for all women is to make sure they have appropriate folic acid. That is the one vitamin you really need in the first part of pregnancy because it helps with the spine development, which is happening before many women even know that they are pregnant. In addition, other dietary modifications can be if ladies are on fad diets, if you're restricting protein or you're restricting carbohydrates, or you're doing the 17-hour fast, but there's so many types of diets out there, which really during a pregnancy, you really need to have 3 meals a day plus 2 snacks, and we'll hit on some of those high points in our question and answer period. When I talk about behavior modifications, that's such things as maybe you're not exercising, you need to be. That's an easy one. Maybe you're not sleeping as well as you should be. Those things may sound trite, but we know those behavior modifications, when put in place, can increase your success in future pregnancies. More important behavior modifications could be tobacco use, drug use, marijuana, cocaine, OxyContin, oxycodone. So there could be some more significant behavior modifications that need to be adjusted. And again, the more these conditions are controlled before pregnancy, the better outcome that you have. We talked about, the importance of the prenatal period, we're going to talk a lot about the importance of the postpartum period. Meaning, if say you had a difficult pregnancy, say you had a condition like preeclampsia or even gestational diabetes, we know women, probably 40 to 50% of women who have gestational diabetes will go on to have diabetes later in their life. And so that's something a woman needs to be mindful of, so they can be their advocate when they're going to have their yearly visits, or even to know, hey, I need to have a yearly visit so that I can make sure this is not happening for me. We know women who have this condition called preeclampsia during pregnancy, which is high blood pressure that's really unique to pregnancy, can be more at risk for certain cardiovascular diseases outside of pregnancy, such as high blood pressure, myocardial infarction, strokes even later in life. So again, it's this information you come armed with when you go see your primary care physician. Lastly, throughout all pregnancies, we need to make sure our women have emotional support before they're pregnant, during the pregnancy, and after the pregnancy. And so we'll hopefully talk about that more when we hit our cute question and answer period. Next slide, please.
So the question is, where do you get your care? And so many women who are contemplating pregnancy or even not contemplating pregnancy are generally young. And we know that healthy young people tend not to follow up with any sort of health care. They feel like they're in good hands or they're in good health and therefore don't need to go see a physician. Some also don't have insurance to go see a physician or a primary care provider. And so for those who do have insurance, use it. You're paying for it. Make sure that you're going for your annual visits, whether that be with your OBGYN, with your primary care physician, family practice physician. Talk to your partners, trusted adults, trusted friends. Try and figure out, if you don't have insurance, how you can get care. There are free clinics that provide basic medical care in various communities. You can take advantage of those opportunities. But basically, you need a health advocate. You need someone who is on your side, whether that's a friend, or if you have a longstanding relationship with a medical provider, whether that's that provider. But you always want someone who you believe and truly feel has your best at heart. And so in this circumstance for pregnancy, you want to, as I said before, always keep yourself sort of at the ready. You don't want to discover an unintended pregnancy and then realize that you have 10 bad habits that you now don't have an opportunity to change before that baby is on. So again, just being your best advocate and finding someone to support you in that endeavor.
Next slide, please. And so, with this in mind, typically people thought, okay, you get pregnant, you get through the pregnancy, woo, you're good, it's over. But we recognize, again, as we've been alluding to in this introduction, that there are many disease processes that happen during pregnancy that have implications after pregnancy. And so with that in mind, the American College of OBGYN actually redefined the postpartum care period in 2018. It used to be a woman would have one visit, and typically that visit would be about 6 weeks postpartum. But recognizing that women have issues during pregnancy and need to be followed longer and more frequently, now the paradigm, and we want to make sure all women know this, is that you really have 2 visits in the postpartum period. The first visit usually is at 3 weeks, and then the second visit should be no later than 12 weeks after delivery. So a woman who has, for example, high blood pressure during a pregnancy, at least 2 times post-delivery, in the immediate 3 months post-delivery, they should be seeing a provider. And as the previous slide showed, ideally it's the obstetrician gynecologist, but it could be a midwife, it could be a primary care physician, it could be a nurse practitioner, it could be a family practitioner, but we want to make sure everybody who's on the team, no matter what the team players, what their names are, everybody knows that patients should be coming in at least 2 times. We also want patients and providers to recognize that postpartum care is an ongoing process. It's not a single encounter, meaning there might be many things you have to follow. And we want to start thinking about what we need to follow during the pregnancy. So we have this anticipatory guidance. What's our plan for the postpartum? And that really that's a discussion that should be had during the pregnancy. And a part of that discussion should be a woman's reproductive life plans. Do they want to have another child? Should they be having another child? There are some complications of pregnancies that really preclude a woman from having another pregnancy for fear of the woman's life. And so those are discussions that should be had. It's difficult to have them during pregnancy because there's so much to talk about, but those are certainly discussions that should be had near the end of the pregnancy and certainly in that postpartum period. And most importantly, you know, the risk assessment, like what's the woman at risk for, really should be individualized. We call it precision medicine in other fields of medicine. I believe we should start calling it precision medicine when we think about women's health as it relates to pregnancy.
Next slide.
So this was just a quote that I amended. So Michelle Obama had said previously that, you know, our communities are based on how strong the health of our women. Well, I added that our families, our community, our country, and ultimately the world are only as strong as the health of their women. And so with that said, we want to open it up to a facilitated discussion with questions that we have prepared, as well as questions that you guys may have for us. Thank you.
All right, thank you very much for that introduction. I appreciate that. All right, so our first question that we have prepared is what kinds of chronic health conditions or illnesses can impact a woman's chances of having a healthy pregnancy and a healthy baby?
So I'll field that one. This is Dr. Aina again. So the kinds of chronic health conditions can run the gamut. There are basic ones that people don't think about, like hypertension, if you will, or borderline. Some people have borderline hypertension, they're not on medication. Some people are simply a little overweight, higher than their recommended body weight. Things that most people don't think about or evaluate on a daily basis, to more involved medical conditions where people are on chronic medications, such as for diabetes, for autoimmune disorders that are more prone, especially to women of color, like lupus. Those kinds of conditions can significantly impact a pregnancy, and so should be evaluated, well controlled prior to considering getting pregnant.
The other thing to add there is that in addition to the medical condition that we want to control, sometimes there are medications that are used to control that condition outside of pregnancy. Great, but those medications may have potential effects on the developing fetus. So one of the benefits of having this preconceptual care visit is that not only to optimize the medical condition, but to make sure patients are on medications that are consistent and safe to use during pregnancy. And it's ideal if medications are going to be changed, they're changed before a woman gets pregnant, because many medical conditions, when they're relying on a medication to control that condition, if you stop the medicine during pregnancy, that period of time when there's no medication on board can lend itself to poor pregnancy outcome.
Thank you. All right, so we'll go to our next question. Maybe. I'm still on annotate. Trying to do too many things. Here we go. Okay, so what kind of outcomes can occur for either mom or the baby if things like high blood pressure, diabetes, thyroid disease, or some of the other conditions that you guys just talked about aren't controlled before or during pregnancy?
So this is Dr. Neal. I'll start this one. One of this, I don't know if you want me to touch on this unintended pregnancy. So what the slide is saying is about 45% of pregnancies in the US are unintended.
Oh, sorry.
But this is related because, you know, if a pregnancy is unintended, it may mean that a woman has an underlying medical condition that she wasn't expecting to be pregnant with, and then they can have adverse outcomes. So for example, with high blood pressure, many people know about high blood pressure. High blood pressure in pregnancy, when not well controlled, can lend itself to early pregnancy loss, so miscarriage. It can lend itself to fetuses not growing well during pregnancy, and we'll talk more about that. It can lend itself to this thing called preeclampsia, which can be associated with seizures, liver failure, kidney failure, intracranial hemorrhage or bleeding in the brain. Women can get quite ill and even die from this condition. And we know the worse the blood pressure is going into the pregnancy, the more risk there is of that. We also know there's a higher risk of what we call placenta separation or placental abruption in the setting of high blood pressure. And then if blood pressures are not well controlled, there's a risk to the mom, not just to the pregnancy, but the biggest risk we worry about with moms with uncontrolled hypertension is the same risk we worry about outside of pregnancy, which is stroke. And so, or even myocardial infarction or heart attack. And so these things can happen. The thing that's mostly in the favor for us for our own pregnancy is most of our moms are young. So even if you have really significant high blood pressure, the rest of your organs are young. So they typically can tolerate some higher blood pressures than say somebody who's 60 years old with that same high blood pressure. But with that said, we still want to make sure that blood pressure is controlled. Similarly, for diabetes, we think about the mom and the fetus. So for the fetus, one of the big things we think about with diabetes is early pregnancy loss, so miscarriage. We also know once you make it through that first part of pregnancy, there's a high risk of structural abnormalities to babies born to moms who have diabetes, particularly those abnormalities that impact the heart and the spine, but really any organ system can be impacted. And then babies born to moms with diabetes can be too big or too small. And we'll talk about that, what those things mean. There's a high rate of preeclampsia with ladies who have diabetes when it's not well controlled. And there's a higher rate of we call maternal end organ damage, where because of the diabetes, both high blood pressure and diabetes can sometimes be silent diseases in the sense that you have them and you really don't have any symptoms until you're really far gone. But during that time period, we know both of these conditions can impact a woman's heart, can impact a woman's kidneys, can impact a woman's eyes. And then that leaves you with other disease processes along with the inciting events. Along with the diabetes or the high blood pressure, you also have kidney failure. And then that increases your risk for these poor outcomes of pregnancy that we're talking about. Go ahead, you wanted to talk?
Just jumping in there. So the other part of this is that if your diabetes or the blood pressure is in some control, but you're using medicines that we typically don't continue in pregnancy, some of those medicines have implications for birth defects, especially in the setting of high blood pressure. There are two large classes of commonly prescribed medications that can lead to permanent kidney disease. And since I think your next slide is going to deal with this, the unintended pregnancy rate is so high, the worry is that if you are even contemplating becoming pregnant, or you know you're not using a specific form of birth control, the risk is that by the time you discover you are pregnant, most of the organs of the baby have formed. That formation of the critical organs, the heart, the spine, the limbs, is done by 6 weeks. And the way that we date pregnancies, 6 weeks pretty much is when a woman first misses a period. So that's 4 weeks in, and then she says, hey, I'm late. And then she's waiting, maybe it's just late, maybe, by the time she does the pregnancy test, pretty much everything is formed in the fetus, and you've missed that opportunity to change your medications and prevent a possible birth defect.
That's a great segue into our next question, which, yes, approximately 45% of pregnancies in the US, which is a pretty high number, are unintended. And unintended pregnancy obviously increases the risk of complications. It also is definitely increasing the likelihood that the pregnant person has not had a dedicated pre-pregnancy counseling session. Knowing that, when should preconception education begin, and what types of providers should be involved?
So I'll start that one off. I think if you have a patient between the ages of 16 and 50, and they are sexually active, it should be an ongoing discussion. What are you using for birth control? That is not limited to the OBGYN. A primary care provider has an obligation to say, hey, you're on these medications. You know, if you were to get pregnant, this wouldn't be good. Are you using something for birth control? So that discussion should be constantly had. If you have a patient that has multiple medications, I think if it's a young female, you have to always consider at any point in time that woman could be, or a girl in this day and age, can become pregnant. And so you have to remind that patient, because it's not always on, in the forefront of their minds, that, oh, I could get pregnant. There are a lot of misconceptions out there. Some people believe, oh, I have lupus, therefore I can't get pregnant, or I have kidney disease, I can't get pregnant, or I have PCOS. Someone has evaluated me for fertility in the past, I can't get pregnant. We all have seen those women come in suddenly pregnant. So I feel like if you are seeing a patient who is of childbearing age, you should be having that discussion. You should be prepping. And if a patient specifically says to you, I'm contemplating pregnancy, I think it behooves you, if you're a primary care provider, to look at them in totality. Look at what is your medical issue? What is your, your health status as a whole? Is there something we can improve on to make this a better outcome for you? And if you don't feel comfortable assessing or managing those conditions or changing of those medications, then send that patient on to someone who can. Send them to someone like Dr. Neal or I. We love doing preconception care to get a woman in their most optimal health before pursuing a pregnancy.
The other thing to add is that, and a lot of young people may remember this, patients and providers, that, when Retin A first came on the market, which was the medicine that's used for acne, everybody flocked to it. It was the best thing we had for acne. And everybody knew that that medicine was what we call category X in pregnancy. Like you definitely never use it. Many drugs are in are in category C, where they can be used, or we don't think there's a harm, or maybe there is, but there's some specific things we definitely don't use. But when that came on the market, everybody who got that prescription automatically got contraception. That you could not get that prescription without getting contraception. But yet other things where you have poorly controlled diabetes, nobody even asked the question about whether the patient is using contraception. So I think if we could all, as a medical community, when you think about what types of providers should be involved, that's saying anybody who touches a woman, like as Dr. Aina said, between the ages of 16 and 50, you have some older women getting pregnant, but definitely 16 to 50, then one of the questions should, all part of your questionnaire is like how you're feeling also should be, are you sexually active? And then what type of contraception are you using? And so these providers, I could again run the gamut. OBGYN, primary care doctors, nurse practitioners, midwives, you go to an urgent care facility because your blood pressure is high and they refill your medication and they're giving you a lisinopril, which is the type of medicine we don't use in pregnancy and you're young. One of the questions should be, what are you using for contraception? I think the more that we move our women's health questionnaire out to everybody in medicine who touches women, I think the better we're going to do in terms of pregnancy outcomes, particularly in the setting of unintended pregnancy. The other thing I wanted to just share a little bit at this point about the unintended pregnancy is that, again, the one thing we need, everybody needs this, is the folic acid. And we, in countries like Ireland, before they had a huge folic acid campaign, they had a very high rate of what we call spina bifida and neural tube defects. And once they started that campaign, the incidence of those disorders went down. We've done a great job in the United States, but I think because patients are touching the healthcare system in many different points now, like I said, a lot of them freestanding urgent care centers, a lot of patients get their care there. People are forgetting that. That's one of the most important things everybody should have, whether they have high blood pressure, diabetes, or nothing at all. Everybody should have their folic acid. That was one point I wanted to add. And the other point I want to add, and it's sometimes difficult to talk about, is like, why is a pregnancy unintended? So one of the things we worry, sometimes pregnancies are unintended because the woman doesn't really want to be pregnant. And we do know there is a link between unintended pregnancy and domestic violence. So I think it's important for providers to be able to recognize that if someone's presenting to them for their kind of first touch in the medical system to find out they're pregnant and they say, I really did not want to be pregnant, to make sure we make inquire and make sure women are safe in their environments.
That's wonderful. Thank you for that point. I didn't have any questions about the domestic violence on here, but thank you for bringing that up. I appreciate that. All right, so like we were talking about with planning pregnancies and pregnancy goals, and the whole gamut of providers that should be involved, providers who aren't OBGYNs might not be experienced or comfortable starting that conversation about pregnancy goals. Do you have any recommendations on how to talk to your patients? I think Dr. Aina did a pretty good job earlier of kind of starting that conversation, how to talk to our patients about reproductive goals.
So this is Dr. Neal. I'm going to start, and then Dr. Aina will join in. So always with everything, I think humor can go a long way. So what I mean by that is like just be light with patients, and anybody between the ages, anyone who's menstruating potentially can be pregnant. So in our mind, an easy question would be, okay, would you like to be pregnant at this time? So if you're not comfortable talking about contraception options, the easy question is, would you like to be pregnant this time? And it's always interesting the responses you'll get. You either get, are you kidding me? And there can be some humor, and you can go with that and say, okay, well, if you don't want to be pregnant, what are we doing to prevent that? And then you can, the patient can say what they're using or not using. And then if the provider is uncomfortable to talk about all the options, say, well, I have a great doctor I can refer you to talk about those options if you really don't want to be pregnant. And on the other arm of that, if your response is, do you want to be pregnant? And the question is yes. And then you say, well, what are we doing about that? I see that you have X, Y, and Z, high blood pressure, diabetes. What are we doing about that? So those are just like easy questions where you're not necessarily have to talk about the different forms of contraception, and you don't necessarily have to talk about the adverse pregnancy outcomes that are associated with a medical condition. Just asking the patient, do you want to be pregnant? And then based on their response, directing them in a direction to a resource that can further kind of delineate the patient's choices for resources.
And I think Dr. Neal touched on this earlier. With any healthcare encounter, we get a history. And part of that history is the social history. And the social history always includes, are you using recreational drugs? Are you single, married, in a relationship, sexually active? Those sorts of questions. Because you need to know, based on what they're presenting for, what could the possible impacts of that social setting have on their health. And so as part of that social history, when you're asking, are you in a relationship? Do you feel safe at home? In asking those questions, you can also insert are you sexually active? Are you using anything to prevent pregnancy at this time? And if they say no, are you interested in it? If they say yes, you can refer them on or have a conversation if you feel comfortable. But if they say, no, I'm not using anything, and no, I'm not interested in preventing pregnancy, then you say, okay, so in this sort of situation, you could get pregnant at any time. Here are the things that I see in your medical history that we've taken that might impact a future pregnancy. How about we talk about that and just leave it there, so you don't necessarily, like Dr. Neal said, have to get into the nitty gritty of medications and options and the pill, the ring, the IUD, but you can at least field an initial encounter and refer them on if they need it.
And the other thing I would add to that is that, for the providers who are on the call, I think it's nice just to have a couple of your resources, like a couple OBGYNs that you feel comfortable referring your patients to. We're here definitely in Howard County for maternal fetal medicine. If it's really a complicated patient, like Dr. Aina said, we love doing preconceptual visits because we know it's going to optimize the patient's outcome for pregnancy. So I think it's always good to have a list of your referring, like who do you like to refer to, and that way you can send the patient on or pick up the phone and call your referring doctor and say, hey, I have this patient, I'd like to send her to you, and we get her in. Definitely somebody who has complicated medical history wants to be pregnant, and the person who has complicated medical history who doesn't want to be pregnant, but who is not on contraception, you can have a favorite gynecologist that you can send that patient to. But none of us know everything about everything. I think the importance right now is just kind of know what you know and know when it's time to refer on, and have a good set of referring friends.
Awesome, thank you. So this kind of goes to what Dr. Neal was talking about before with the continuum of pregnancy care. What if your patient or client has already had a child? Is it still important to talk about their pregnancy goals? And what role does pregnancy spacing and care play in healthy pregnancies?
So I'll field this one initially. It's always funny when you have a patient who's had 2, 3, or maybe they're on their 4th kid, and they come in and they make comments like, oh, this is old hat. I've done this, been there, done that. I know what I'm expecting. As maternal fetal medicine doctors, we understand that every pregnancy, even in the same patient, can have very different outcomes. And so our job, sometimes, the patient's relatively healthy and we can leave them in that belief that, oh, I've had 3 of these, nothing's going to happen. But in the back of our minds, we know that things change over time. Number one, you're older. And just with age, your risk for certain things go up, including blood pressure and diabetes. Number 2, did your weight change between babies? Did you manage to get that baby weight back off? So are you starting in the same condition that you started the last one? And then we ask questions about, how did that pregnancy go? Did you have complications? Did you have diabetes? Did you develop blood pressure? Because we know that women who had a complicated pregnancy the first time are more likely to have the same or worse consequences the next time. And so we try to encourage women who are having complications of pregnancy that it's really important between pregnancies that we follow up on this, that we get this under control, that we evaluate what put you at risk for these complications so we can try to prevent it the next go round. And one of those things is how close together pregnancies are. Some women feel like, I just need to bang them out and be done. Get 3 in 3 years and then I'm finished and I can move on with my career or the rest of my life. But we do know that when babies are spaced too close together, that there are increased complications to that. And what do we mean by too close together? Well, the definition is that if a pregnancy that is conceived within 18 months from the last delivery is too close. So we are trying to get the word out to get patients to understand you don't want to become pregnant until that last child is at least 18 months. So ideally, your babies should be almost 2 to 3 years apart. The ones that come every year have, it's more of a strain on mom, but also can impact baby. And so that's the concern with spacing. But again, if you had a complication in one pregnancy, you're more likely to have that complication or worse in the next. And if you didn't have a complication, simply by age, you're at more risk in a future pregnancy.
And the only thing I would add, like, to people say, well, what exactly is it? What's going to be the problem? What's the big deal? We know that when those pregnancies are spaced too close together, when Dr. Aina was saying there's a risk to the fetus as well as to the mom. So in terms of the mom, we know babies take everything from us. People, say it's an old wives' tale. They say, oh, I lost all my hair in the pregnancy. My baby took everything from me. But we know really the fetus is very smart. And the fetus will take all that it needs to try to make his or herself the best he or she can be and leave mom with nothing. And if you do that back to back to back to back, moms will actually get depleted of significant and very important minerals and vitamins. They become significantly anemic. That can actually, in severe cases, lead to heart failure. So moms can get quite ill just from being depleted basic kind of, like I said, minerals and vitamins that they need. And it sounds like trivial, like how could that possibly happen? It happens, particularly in moms who are breastfeeding. So they are pregnant, breastfeeding, pregnant, breastfeeding, pregnant, breastfeeding, and then pregnant again. And they never really had a chance to kind of build back their reserves. And if you don't build back the reserves, it's like I said earlier, the fetus is smart. So typically the fetus will take everything it can. But if there's nothing to give the fetus, the big risk one of the big risks we worry about with closely spaced pregnancies is fetal growth restriction, when the second, the current pregnancy won't grow well, when the baby won't grow well. And again, because fetuses are so smart, sometimes when they're not growing well, they say, okay, maybe I should get out. And so there's a higher risk of preterm labor in the setting of closely spaced pregnancies. And particularly if you've had cesarean delivery, C-sections, we know that with the C-section, that puts you at risk for a certain way that the placenta lays down, something called placenta previa. And that's where the placenta is kind of coming in front of the cervix. That lower part of the uterus near the cervix is not the best vascular supply of the uterus. And therefore, often babies don't grow well with the placenta previa sitting there. And more importantly, over time, sometimes that placenta will kind of invade into the uterine wall and cause something called placenta accreta. So that can cause significant hemorrhage at the time of delivery. So not only are you thinking about spacing the pregnancy out for the fetus and for the mom in terms of depletion, but let the uterus heal. The uterus needs to heal. So it's very important to try to give that 18 months. The only caveat I would throw out there is that we do know that more and more women are delaying childbirth. And so you may have a woman who's 40 having their first baby, and they say, because of the chromosomal risk or genetic risk associated with advancing maternal age, they don't want to wait that 18 months. They feel like they don't have enough time. And so we do see women who are older having the closely spaced pregnancy. But guess what? Women who are older often will have other underlying medical conditions that already put them at risk for adverse pregnancy outcomes, such as babies not growing well, preterm labor, more hemorrhage, C-section, and then you put on top of that a closely spaced pregnancy, and then bam, you've got like it's not necessarily a cumulative double risk, but you definitely have an increase in the risk. So, there's no, we don't have a crystal ball, so we don't know who's going to get what, but we just try to do our best in terms of, again, giving that precision care, like I was talking about, like individualized risk. So when you see a patient who's had a child, the pregnancy may have gone great, but then talking to them about their pregnancy goals will help in terms of setting up, like, what are their risks? What are their individualized specific risks for that patient for future pregnancy?
Thank you so much. That answer was incredible. I really appreciated that. Let's go to the next question. So we touched on this briefly, but birth control can be a very sensitive topic based on a person's religious or cultural background. We have discussed birth control several times throughout this presentation, but what role does it play in a person's reproductive life course? And do you have any tips for providing that kind of education in a culturally aware manner?
So, birth control doesn't necessarily mean medication. So there are some religious and cultural backgrounds that feel that you shouldn't intervene medically in the whole reproductive process. But those same backgrounds also do not restrict you from timing intercourse or timing relations so that you can try to prevent a pregnancy. And so usually we try and incorporate a patient's beliefs. Certainly you don't want to force anything on a patient. That's a great way to remove that patient from obtaining medical care, and you don't want that. And so it's just a matter of having a conversation. What is it? What are your goals? What do you want? Are you done having children? If the patient is done having children, but their religious or cultural backgrounds do not allow them to use medication or surgical intervention or anything to prevent a pregnancy, then you have to educate them on their bodies, have them record their menses so that they can try to figure out, teach them when is their most fertile period so they can avoid intercourse during those times. All those sorts of things that you can do without coming up against their religious or cultural restrictions, if you will.
And I agree with Dr. Aina. I think just having a conversation, I was saying earlier for the other question, you know, just having a conversation, that's like a humorous, but a serious conversation, like, if you don't want to be pregnant, what are you doing to prevent it? How can we help you prevent this? So I was thinking we always use we like to use the word we. We're a team. We're working together. We want to respect, you know, your desires, you know, may not have anything to do with a person's religious or cultural background, just their desire. What does the patient desire? And so I think it's always helpful. It can put a patient at ease when you say we. How can we work together to achieve this goal? If that goal is not to be pregnant, how can we work together to achieve that goal? And if your goal is to be pregnant, how can we work together to achieve that goal?
Thank you. All right, so I know that you both are experts in women's care, but what role, if any, does preconception education and counseling have for the care of men?
So I'll start this one. So I looked at this question kind of on with two lenses. So my first lens is that I think it's important when we're caring for our women, for our men to understand where we're coming from. So before COVID, you know, we really enjoyed having our men, partners, husbands in the visit with us, so that if we were talking about something, they could hear what we're talking about, and so they could understand if a woman said, you know, I need to avoid pregnancy until I can fix my diabetes or my high blood pressure, the men have understanding why. And I want to share a story, a really quick story with the group. This still resonates with me. You know, our patients are very savvy. And over the last 3 to 4 years, there's been a lot of attention nationally, internationally, in terms of racial disparities and healthcare outcomes, and really how Black and Brown women are not faring well in pregnancy. So I had a couple come into the office, and the patient wanted to be pregnant. She had high blood pressure. It wasn't terrible. I've seen much worse. It wasn't terrible at all. They had one child, and the husband came with her, and he almost cried in the office, actually where we're sitting right now, and said, you know, I don't want her to have another pregnancy. I've seen all the articles. I know that Black women die in childbirth. And so I was glad he was there. I was happy to be able to share with him really the information so he could be walked down a little bit off that tightrope, that his wife didn't have that high blood pressure. Yes, she had some risk, but it wasn't terrible. But for him to hear the counseling session, I think helped him tremendously. He wanted to expand his family. Like they had a seemed like a solid relationship. They wanted to expand their family on one hand, but he was really fearful that he would lose his wife and his daughter would not have a mother. So by him being a part of the preconceptual counseling session helped him understand the risk in a more accurate context. And I think they ultimately expanded their family, and she had a good outcome. But it was really helpful for him to be there to hear that, to help protect him. And sometimes it's for the men to be there so the women feel like they have a comrade in this. You know, it can be very isolating with, say, with diabetes, a woman's checking her blood sugars 4 times a day. We're saying don't get pregnant until your blood sugars are well controlled, and she really wants to be pregnant. The husband really wants to be pregnant. And if he doesn't know why she's still using contraception, that can be very isolating. Like she's doing a lot of work to be healthy, and it's good to have a comrade. So I think it's helpful for the men to be a part of the session, for them to understand what is happening with the women. I'll let Dr. Aina continue.
The other thing that I would bring up is that we know that culturally, and you know, for some patient populations, if a woman is not getting pregnant, it's her fault, and she gets blame, and she feels guilty. It helps to have the men at these education sessions, like Dr. Neal said, to understand if her diabetes isn't in the best of control, she's going to keep having a miscarriage. Or, you know, if she has high blood pressure and the baby is so small and she has a premature birth, that's a bad outcome. And so to hear what the mom has to do to get herself in the best health sometimes helps. But by the same token, if a woman isn't becoming pregnant fast enough, if you will, it sometimes helps to hear that the male's behavior has a role in them getting pregnant. We have husbands who smoke a lot, husbands who drink a lot. And sometimes you don't get at that, or the woman doesn't feel comfortable broaching that topic, that this may not be my I hate to use the word fault, but that's sometimes how the woman feels if they're not getting pregnant readily. It's not my fault that I'm not getting pregnant. And so sometimes it helps for the husband to come so that he understands that this is a partnership. And so it may not be something the woman is doing or not doing. It may be something he's doing or not doing that's preventing them from getting pregnant. I can't tell you how often we hear the phrase, oh, well, I had a daughter in a previous relationship, so I know it's not me. That's the man talking. And we all know that making sperm is a continual process. Things affect that. Alcohol affects that. Smoking affects that. Age affects that. And so it may not be that the woman isn't just, isn't becoming pregnant and she's the odd one out because the other woman got pregnant. It may be that you've changed since the last time you created that pregnancy. You haven't, kept yourself in the best of health, and that's what's impacting the two of you in getting pregnant. So we don't deal with the infertility patients as much in terms of providing a plan to become pregnant, but we certainly talk to people who have struggled and who have had multiple early losses and try and figure out what is it that we can change to better optimize your health moving forward so that that pregnancy does continue. And it helps for the men to hear that.
And one last piece to add to that for the men to hear is that, we've been speaking a lot on like preconception education regarding chronic medical conditions. But one of the things we see a lot is that, as I was saying, a lot of women have delayed their childbirth birthing for career development, things like that. And so with that delay, that means women are getting pregnant at an older age. And so there's a higher risk of some of the chromosomal or genetic conditions. And so one area I find very helpful for the men to be a part of is that conversation about what is the risk of genetic conditions, say like Down syndrome, for a woman at this age versus this age versus this age. So they understand like, hey, maybe if I've got risk, because I'm 40, just based on my age, I shouldn't want to have twins. You know what I mean? And plus I have high blood pressure, so I should not want to have twins. So a lot of it's important in that context to understand like what's the impact of age on women, and that sometimes men, our partners, ask a lot of us, and we become the heavy to say, hey, because we've got X, Y, and Z, perhaps you don't want to have twins. I'm just using that as an example. Or perhaps we need to get this pregnant. You need to get your medical conditions under control, because we can't change age. I always talk to patients about things that are modifiable and things that are non-modifiable. So age is a non-modifiable risk factor. Once you're 40, you're 40. You can't go back. However, if you're 40 and your BMI is 40, you can definitely change the BMI, and that will then adjust the risk. So I think sometimes it's good for the men to hear that in the preconceptual education piece.
And to that to that thought, including the risk of genetic conditions. So not only does the woman's risk increase with age, the man's risk to the pregnancy. So we often think that it's just the woman's age that has an impact, but we do know that the risk for autosomal dominant conditions, so genetic conditions, increases as the man ages. And so men over 50 particularly have a higher risk of having a child with a new mutation. And that has nothing to do with the partner's age, the woman's age. And so to have that conversation helps, especially as we see more 60 and 70-year-old men with 40 and 50-year-old women. It helps to have that conversation up front and to have the discussion. I think the hardest thing that we probably encounter during a pregnancy with our patients is to have a couple who is discordant on what to do with an abnormal pregnancy. I think during a pregnancy, when it's counting and you're under pressure, is the last possible time to be thinking, oh, I would want to continue regardless versus, oh no, this is a no-go area. We have had patients who've ended up in counseling, some who've ended up in divorce because of a discrepant view plan for a pregnancy that's going to be challenged, or a child that's going to be challenged. And so to have those discussions, a lot of people, you know, understandably walk into these things, they think it won't happen to me. But to at least have had that conversation, well, what happens if they say there's an increased risk for us? Or what happens when we do amniocentesis that carries a risk to the pregnancy? What happens if they say the baby has a bad heart defect? Are we going to continue? Is that our plan? We're going to go regardless? I think it helps for the man to hear that so that the first time they're hearing it is not at 20 weeks when we found the defect and the woman says, I don't want to continue, and the man is not on board with that plan.
Well, I don't know what I was expecting with that question, but that was an incredibly robust answer and I really appreciate it. We only have a few minutes left and this next question could take another 4 hours, 20 years of discussion, hopefully not 20 years, but I want to give it some time. So severe maternal morbidity, maternal mortality, prematurity, fetal and infant death impact families of color at significantly higher rates than white families in Maryland and across the United States. Can you talk, I know this is a hard task in just a few minutes, but about the role of race and bias in pregnancy, and whether or not improved preconception care could play a role in impacting those disparities?
Absolutely. We can at least start the conversation. I think Dr. Neal mentioned this before. We do know, and it's becoming more prevalent in the medical community so that more providers are becoming aware that race is playing a role in outcomes, that implicit and explicit bias in medical care plays a role in medical outcomes. And so for pregnancy, it's no different. And for our pregnant populations, we do, you have to individualize care, as we've been saying all through this webinar. You can't treat all your patients identically. Some women are more at risk, and you have to understand that, and by the same token, act on that. It isn't you being preferential or having a negative bias in that situation. If you know that your woman of color is more apt to have an adverse outcome, and therefore maybe you bring her back more frequently than your Caucasian patient. All those things play into it. Preconception care can help. We do know, certainly, as we've talked today, that improving the health prior to pregnancy will improve outcomes. And so definitely trying to get your patients, all patients, in for preconception care is the ideal, but certainly your women of color, trying to encourage them to try to get in their best health. We know that the risk of unintended pregnancies are higher in that population, and therefore we should basically keep those women at the ready. If you're not going to talk birth control, at least manage their medical issue. If you're not going to, so to keep them in their best possible health at all times will improve pregnancy outcomes. If you can specifically get them in for preconception care, wonderful, but we know that that's not reality. And so if we just treat all of our patients that are of childbearing age as a possible pregnant woman, and try and keep them in their best possible health, I think we would improve outcomes for their pregnancies, unintended or otherwise.
And I just want to add also too, for the patients who are on this webinar, I think the more times you interact with the medical system, the better you get. And what I mean by that is, as a patient, I would advocate for you to use your preconceptual care as practice. I want to know, what does it mean if I'm going to be pregnant with X, Y, and Z medical condition? What should I be having? In addition to us optimizing the medical condition, laying out a plan, what would pregnancy look like for me? And therefore, if you once you move on to your OBGYN or your midwife, you have as a patient, you have in your mind what you should be getting. Because sometimes, you never know who you're going to get as your provider, but if you know what you should be getting, at least that's you're just one step ahead. That if you see something not happening that should be happening, you've already had a conversation with another provider that this should be happening. So I think from a patient's lens, I think preconceptual care helps. It's like a muscle. The more you flex that muscle, the stronger you get. And then with more information, I firmly believe, information is power, and that you can use the information you receive in your preconceptual care to carry it forward in your OB care. And it's like, I know I should be getting these things. Where should I be getting these things? It's number one. So I wanted just to throw that out there in terms of our patients on the webinar. The other thing is for providers, if a patient's coming to see us for preconceptual care, we do lay out a plan and we send that plan on to the provider. So it's just one way of trying to leveling the playing field in the sense of if say the provider, isn't comfortable with or not familiar with a certain condition or does have some implicit or explicit bias, at least if there's an objective plan that's laid out in the patient's medical record, there's a chance that plan may be followed, and that could help, alleviate some of these disparities. But most importantly, I want to just leave with the point is, the patients can come with information. You come with information, you come with some power. Because we do want to make sure, at least Dr. Aina and I really, our model when we're caring for our patients, it's a team, we're a team effort. And if anyone's been on any team, everybody has a role on the team, and including the patient.
Thank you so much for your answer to this particular question and to all of them in general. I have thoroughly enjoyed everything that we have discussed today. It is already 5:33 or 5:34, so I'm going to cut the webinar here in respect for everyone's time. I think we had some really great discussion. This has been recorded, so we will also have this available if you have a colleague or a friend that didn't get to attend. We'll share it on our website, and then we'll also send it to all of the attendees for today. So again, Dr. Aina and Dr. Neil, thank you so much for your time and your expertise. This has been really a wonderful discussion, and I really appreciate you.